The recognition of the existence of silent myocardial ischemia was documented in the early 1970s. Of course, at that time, no one termed these changes silent ischemic events. It's only in the last decade that this term has been commonly applied.
Many years back, there was a general feeling that asymptomatic myocardial ischemia is not as bad as symptomatic ischemia, and people thought, well, once it becomes really dangerous, the patient will feel it as chest pain, as angina, as one of those equivalents. But we have learned in the last year that there's a considerable overlap, and even severe ischemic episodes may be completely asymptomatic. And the more you look for that, the more you actually see that. We have learned a lot from ST segment Holter monitoring within the past years. We have seen first that myocardial ischemia is much more common than anticipated by taking history alone. If the patient tells us, you know, I'm feeling okay, I have about 1 episode of chest pain a day, and you look at the Holter and you see he has 3, 4, 5 episodes of ischemia, which he just was not aware of, you really get scared seeing that there's so much ischemia around.
Silent myocardial ischemia can occur in a number of different patient types. These include patients with a history of angina pectoris or myocardial infarction, or people who are totally asymptomatic with absolutely no history of heart disease. The incidence of totally asymptomatic silent ischemia is thought to be in the range of about 4%.
So I think it's justified to say that asymptomatic ischemia may be as dangerous as symptomatic ischemia. And indeed, 2 recently published prognostic studies have shown that in patients with an abnormal treadmill test, the presence of additional silent ischemia really increases the risk for further cardiac events. So it looks like silent myocardial ischemia is an independent risk factor for the further development of cardiac events. Risk factor not in the sense as high cholesterol or smoking or hypertension, but risk factor in the sense of patients with proven coronary artery disease and silent ischemia are at a higher risk for further developing a fatal or non-fatal cardiac event than those patients with coronary artery disease and no silent ischemia. I do not think that silent myocardial ischemia is a new disease which requires new drugs or different drugs. You can treat silent ischemia with all those drugs which are effective in angina pectoris. There's no clear evidence that the pathophysiologic mechanisms leading to silent ischemia are really different from those leading to angina pectoris. In the early days, it was thought that silent ischemia is more related to vasomotor changes of the coronary arteries, and angina pectoris is more exercise depending, so silent ischemia is more a supply problem and angina pectoris is more a demand problem. But the borders are not clear, and silent ischemia may be also very often be a problem of oxygen demand.
Nitrates are very effective in the treatment of both angina pectoris and myocardial ischemia, including silent ischemia. Analyses of changes in left ventricular global and regional myocardial wall motion suggest that nitrates have the potential to prevent or ameliorate the consequences of silent ischemia. They work predominantly by venal dilatation and reduce preload by shifting the blood from the thorax into the abdomen and to the lower extremities. This is a very, very important mechanism in the treatment of myocardial ischemia. Other groups of drugs, such as beta blockers or calcium channel blockers, do not have this important mechanism of action. In addition, there may also be some coronary vasodilating effects. We know that nitrates not only dilate pre- and post-stenotic coronary arteries, but they also dilate eccentric lesions.
We have learned a lot about EDRF, endothelium-derived relaxing factor, in the last years, which is a substance released by the endothelium with a very potent vasodilating effect. So it's kind of a built-in protection of the vessels. On the other hand, if atherosclerosis begins, and we know that even in early stages with so-called non-significant quotation mark lesions, the ability to dilate disappears. So the best way to approach this is to substitute EDRF. And surprisingly, it was found that EDRF is not a fancy hormone or polypeptide. EDRF is very simply nitric oxide, NO, which is released by nitrates. So nitrates may be considered to be a physiologic therapy, a physiologic substitute for EDRF deficiency.
There have been concerns about the development of nitrate tolerance as demonstrated when steady plasma levels are achieved. Interestingly, in the United States, the issue of nitrate tolerance arose with the introduction of nitrate patches, which were designed to create constant plasma levels.
At the time when we started our program, 1982, there were several studies published showing that TID or QID dosing of nitrates leads to tolerance. But at that time, no study has been performed with less frequent dosing. We reduced the number of tablets to be ingested, and we started with once daily and twice daily regimen, which was not assessed at that time.
The BID 12-hour regimen with 80 milligrams of isosorbide dinitrate in the oral controlled release form, taken at 8 a.m. and 8 p.m., led to the development of tolerance. However, the 80 milligram dose taken once daily prevented the development of tolerance, and results showed that anti-ischemic effects at the 15th day were identical when compared with the first day of treatment.
So why didn't we stay with the once daily dosing? The once daily dosing, although it prevented tolerance, had not optimal, maximal anti-ischemic effects in the late afternoon and in the early evening.
An asymmetric dose regimen with ingestion of 80 milligrams of controlled-release isosorbide dinitrate in the morning at 8 a.m. and in the early afternoon at 2 p.m. was tested, and also proved effective in terms of coverage and in preventing the development of nitrate tolerance.
And indeed, that dosage regimen in our hands had the best results for anti-ischemic treatment because the patients were fully covered during the day, but the drop-off during the night was enough to prevent tolerance development.
Other investigators have shown that 30 milligram doses of isosorbide dinitrate in non-sustained release form, administered at 7 o'clock in the morning, at noon, and at 5 p.m., provides a nitrate-free interval during the night, while maintaining the anti-ischemic effects during the next day.
All these three different regimens induce a waxing and waning of the plasma levels of isosorbide dinitrate and its two active metabolites sufficient to guarantee the full anti-anginal effects following the next day.
Several studies have documented the fact that myocardial ischemic events occur predominantly during the day and are rare at night, so fluctuating nitrate plasma levels at night is not a serious problem.
Well, this circadian rhythm of sound myocardial ischemia shows clearly that we have to focus our anti-ischemic medication to the day hours. That means we have to maximize the anti-ischemic therapy for the day. I still would prefer nitrates as a first-line drug because they have this unique principle of venodilatation, which is really unloading the ischemic ventricle and is so important. And with intermittent dosing, we gain about 12 hours of anti-ischemic effects during the day, which we have to focus at anyway. But if the patients are on maximal nitrate therapy and they still show signs of myocardial ischemia in the perfusion synogram or in the Holter monitoring, I would strongly recommend to go for combination therapy, to combine the nitrates with a beta blocker or a heart rate decreasing calcium channel blocker. Of course, it's our goal to help the patient to abolish angina pectoris or its equivalents and to bring the patient back to that level of quality of life that he really wants. But on the other hand, we should not stop at this level and be satisfied and say the patient is pain-free, that's all we can do. We still have to check whether he has additional episodes of myocardial ischemia because our goal is not only to abolish angina pectoris, our goal is to abolish all forms of myocardial ischemia.